All right, good afternoon, everyone, and welcome to today's Health Action Council webinar, COVID-19, Reporting, Strategies, and Moving Forward, hosted in partnership with United Healthcare. My name is Rick Westfall, and I am the Director of Education for Health Action Council. Today, we're joined by Kevin Gregory, Vice President of Business Solutions for Health Action Council. And from the United Healthcare team, we have John Elliott, Vice President of Collaborative Ventures, and Craig Kurtzwell, National Vice President, Data Analytics and Innovation. We have assembled this all-star cast today so you can hear the latest on preparedness, response plans, and COVID-19 testing. We'll also take a look at Health Action Council member data, as well as reboarding and plan design strategies. Before we begin, I want to remind you that if you have any questions, please use the chat box located on the right hand of your screen. I will be monitoring the chat box throughout the presentation and will pause at the end to respond to your questions. If for some reason you're having any problems with that chat box, simply email me at rwestfall, like the direction in the season, at healthactioncouncil.org. This webinar is being recorded and it will be available to Health Action Council members on our website under the Member Center section at healthactioncouncil.org. For those of you out there who are not Health Action Council members, please again, if you would like access to this recording, please email me at rwestfall@healthactioncouncil.org. And with that, Craig, very simply, I'll turn this over to you.
Thank you, Rick. This is Craig Kurtzwell with United Healthcare. I'll be walking through some of the COVID analytics that we are seeing across the country and specific to Health Action Council. I'll be followed by Kevin to walk through some of the employee reboarding, and then Mr. Elliott will walk through some of the future health plan designs. Let's jump forward. You can go one more slide, actually. As we start to analyze this pandemic, we're doing a lot of geospatial visualization because as you're reading and as you're seeing, this is definitely a very localized and highly variable pandemic across the United States. What you're seeing here is the data that you've seen on the news, but we've created a denominator. So this is looking at confirmed cases per 100,000 citizens, and where the darker the shades are, especially the dark blue, that's where we're reaching 1+% of the population having confirmed COVID. So you can see the hotspots of some of the communities. For example, the news recently, some of the plants and locations in Iowa, Nebraska, South Dakota. You can see some of the blue dots popping up there. So this is no longer just a Northeast issue, as many other parts of the United States are starting to go into the dark shades of red and dark shades of blue. But we know that one of the reasons why those shades are starting to migrate up is because there's more testing. And as there's more testing, there will be more cases that are found. And if you flip ahead one more slide, a key metric that we are starting to transition to, and you should start to see this socialized more nationally, is a view of mortality. As obviously morbid as that is, this metric is probably the most stable metric for actual prevalence and actual spread of the disease, because testing can influence so much of the confirmed cases. Death and mortality is something testing obviously can't influence. And a lot of this holds true to the slide you just saw, but gives us a different way of making sure that we're not just highlighting those communities that are just testing more. And so some of the red spots start to come out on this design, and we'll start to use this to track the spread of the disease as well. On the next page, we thought it would be good to start to talk a little bit more about testing. And so as you think about where the testing has started to expand, we want to keep track of the exponential growth that is occurring across these states. So as if you've heard me talk before, I'm constantly talking about this sort of dynamic that pandemics grow in an exponential way. And the only way to really track to see if things are getting better is, do you start to diverge from that exponential growth through testing, through quarantine, through stay at home, through all the different efforts that we're doing. And so as you can see on here, many states have deviated from the exponential growth, some showing very, very positive results. Louisiana, Michigan, New Jersey, Illinois, now seeing a downward trend, declining growth in some of those key populations. And we're seeing this in general across the United States from a case perspective. On the next page, we look more into testing, so you can start to see, mortality. Let's start there before we go into testing. So mortality is an interesting view, as I mentioned, a much more legitimate view of the actual spread of the disease. And what you can see in the bar graph here, the bars behind here are the actual deaths per 100,000. So in New York, for example, they've had about 120 deaths per every 120,000 citizens, by far the highest, right? And as you go from left to right, you can see New York's at 120, but there are many states. The vast majority of states are below 20, or below 10, or below 5. So highly skewed toward the Northeast, with New York, New Jersey, Connecticut, Massachusetts dominating the mortality for COVID across the United States, and even adjusting for population. It's not just saying New York and New Jersey are big. The mortality per case, per citizen is much higher there as well. And then you can see the red line behind the scenes here is looking at the rolling trend. So are things ramping up or ramping down? And you can, if you draw a line at the 0 on the right-hand side, that's where above that would mean that mortality is increased, and below that mortality is decreasing. So some key states, Tennessee, Idaho, Maine, Nevada, Louisiana, we're seeing big reductions in mortality. But on the other side, there is growth of mortality in Delaware and Rhode Island, Vermont, and Arizona, key states like that as well. So something to keep track of as you're seeing in the news more and more cases. Just make sure mortality is a key metric to kind of keep in mind for true spread. Next page. Because of what we're seeing in testing. So when we look at testing, it's not just about how many tests are you delivering. A key metric for measuring pandemic is what % of those tests are coming back positive. High variability again, right? On the far left-hand side, if you're in New Jersey, 35% of the tests that are being administered are coming back positive. You can see New York is midway through. They're at about 20, just shy of 20%. Those two states, New York and New Jersey, were at 50, 60% a couple weeks back. So now they're testing more of the population, and more of those tests are coming back negative. And that's a good sign. As you're starting to see that test positive rate come down, that's a good sign that actual spread of the condition has started to mitigate as well. And there are many states on here that are well below 10% of the tests coming back positive. On the next page, we look at that trend. So we can look at, this is looking at a rolling 10-day trend in that positive test rate. And you can see a vast majority of the states are on the right-hand side of this, where they're actually showing reductions in that positive test rate. Very good sign from a pandemic perspective. On the left-hand side, there are a few states, Vermont, Alabama, Missouri, that are seeing an increase of folks coming in and being tested and being positive. States we need to keep an eye on. On the next page, we look at the ability for us to start to understand the differences in the states. And as we start to think about, and we're going to walk through some of this today, as folks start to think about return to work and opening up states and things like that, we've created this state dashboard that takes some of this publicly available data and organizes it in a nice, neat fashion around the key measures you need to keep track of: cases, testing, mortality. And so within this dashboard, and we've color-coded, and these are just the top, I think, 25 states or so based on size, you can quickly start to get a line of sight into where is your state when it comes to the number of cases, the frequency of testing. Have we just not tested enough? Or are we one of the states that are testing a lot and skewing some of our case results? And then looking to see what does mortality look like within our state today, and what is that trending at? As you think about opening up and returning to work, these are some of the key metrics we're starting to share and make some of those decisions, because as you can see on here, incredibly variable. And this is going to be a very localized decision as we come out of this, knock on wood. On the next page, the last analytics slide that I'll walk through, we thought it'd be good to show, this is the reporting that we have available for COVID. You will see this as part of, through your account management teams with United Healthcare. This is the Health Action Council view of COVID experience so far. And so we have 99 confirmed cases at this time, 17 probable with codes that are very likely COVID-related, not 100%, but very highly likely. And then 73 have cases that we think that many of those are probably COVID-related, but we can't completely confirm. We're just shy of 900 tests. Only 56 of the 560 tests that we know the results for came back as positive, meaning we're at about a 10% threshold, as you just talked about. So many of the tests are coming back negative across Health Action Council. And then down below, as we look at those, especially those confirmed cases, we do have people that have more severe symptoms, right? There are many patients that are requiring ER, inpatient, ICU, and even a handful of patients requiring ventilator services. So just an example of what we're seeing, boots on the ground, this is what's happening for Health Action Council. And again, we are running this at an employer-specific basis for you to see from your account management teams as well. With that, I'll pass the baton over to Kevin Gregory.
Thanks, Craig. That's great information. From a Health Action Council perspective, what I really want to do is talk a little about what did we do as an organization. States, the federal government, everything was literally, changing by the hour, and it seemed by the minute at times. At the beginning, what we realized was that the lawyers, the accountants, the bankers, the benefit consultants, and the lobbyists were really going to be managing most of those immediate needs. So we really started focusing in on, well, what comes next? How are we going to get back to work? And what role could we play, in all of that? And one of the things that, as I was thinking through this and organizationally kind of prepping for this was, we had an old member, he's since retired. He always used to say, somewhere along the way, we lost human and human resources, and we became a resources department. So we kind of felt like now is a time, since we're all focusing in on individuals, where they're at, was really a pretty good time to put, kind of human back into human resources. So I think, Rick, if we can move to the next slide. I think the big question is, as we prepared our reboarding piece, we kind of looked at this as lightning struck. It's a little bit like a natural disaster, but none of us, depending on where we are in the country, may have been used to natural disasters. We haven't lived through hurricanes. We haven't lived, many of us may not have lived through tornadoes, and we haven't been told to stay home. We haven't been told, and to make these big business decisions. So we really suddenly would just kind of sit around, and all of us maybe had a little bit more time to think, and then, as the joke goes, and probably drink a little bit too, right? It's funny, but at the same time, when you think about the habits that we form when we're, not, at work or at home, that has a possibility. So you started thinking about positive habits, good and bad, that can come out of this whole process. And what we realize is, Health Action Council kind of positions and looks at ourselves as a long-term thinker, and kind of partnering with, kind of our members and their brokers and consultants, is long-term. When COVID first hit, really was not years, it became weeks. And so it really kind of created this mindset that we had to go out and try something different. And so as we move to the next slide, we set about to find some unique stories that could help us learn from this. We didn't know what to do. We just said, well, if we ask some people the right questions, let's see what happens and see if we can come up with something. So we started interviewing people with different life stories, who had gone through different things. Some of them had been through the war. Some of them had been retiring and transitioned out of work. Some people had been formerly incarcerated. These are challenges that when we started talking to them, we didn't know where it was going to go. But what we found was a pretty consistent theme about being resilient. And we're all unique as what we're doing. And so this whole idea is being resilient that came out of this, and what can you do? And there was also this whole idea around social connectivity that everybody talked about. Even sitting in, the gentleman we talked about who was in the war, he's like, look, we got together in our apartment. We played games together outside. There was this whole idea for social connectivity, because being social as human beings is huge. So we started, talking with this concept that it's not social distancing, but it's really physical distancing, right? Because social distancing means that you're removing yourself from relationships that you have with other people. Physical distancing just means that I'm maintaining my relationship with you. We're maintaining our friendships. We're just standing far enough apart so that we don't spread germs to each other. We're washing our hands. We're taking good basic hygiene steps that we can do to be good citizens of the world and to each other. So as we move on to the next page, one of the things that we came out of this was really, how do we get back to the basics, right? So we try to summarize this, and bring action to what we do. So how do you get back to the basics? A lot of it just talking with your employees and encourage them to talk amongst themselves. Some of us would say, with COVID-19 and everybody working at home, in the office environment, some of our productivity levels may have gone up, right? Because essentially there's nobody stopping by. There's that hall chatter that creates connectivity, but we've had a little bit more productivity at home. But we all have a different story and different ways of doing that. And I'm reminded literally this past weekend of the story about getting back to the basics. My daughter chose to stay at college, and she graduated this weekend. Not physically graduated at school, then virtually, but we went to move her out of her apartment, and her roommates, who I've known for 4 years, all of them said it was really awkward to just have a conversation with another human being. And so we just took the time over the next 6 hours to spend time with one another and learn how to re-engage as human beings and have those conversations. So it's probably going to be a little bit awkward as people kind of get back in and not sure what to do. And everybody's on different spectrums as it relates to this. So as people are coming back to work, people are going to have to be mindful of that. I think the other thing that we learned was, under the mind your mind concept, is just be open to change. There's this whole idea of accepting where you're at and then having hope for the future. And, it's about being resilient. And we think that really the folks who take that time to be resilient and look at reboarding their employees, it's not just bringing them back to work and pretending that it all went, nothing happened, right? And so we don't think that strategy is going to work very successfully. You're going to have to do that. So that's when we talk about communicating, connecting, and co-creating. That's to us, that's putting human back in human resources. Everyone's going to have a different reaction. It's their unique experience. Encourage your people to talk to each other, kind of go through that whole process and thinking about that, because if you don't let people share their story, or they try to bury it, and then, it's no different than, those adverse childhood events that ultimately folks have them when they're young. And then as they get older, they bury those emotions, they bury those feelings. Their cost of care is higher than people who don't have the number of higher adverse childhood events. Make sure that you're giving people the space and time to connect with each other. The fourth one, we talk about celebration. I'll tell you, never in a million years did I think that people would talk about celebrating. But it was really this, we won, we overcame it, and it kind of created this sense of optimism. I think that, as Craig talked through kind of where we're at, and as things kind of roll around a little bit, I think celebrations may be a little different around the country. But I think that each employer, there's an opportunity to create a celebration, create some connectivity, and kind of reposition where they're at. And then we talk about getting ahead of the game, right? What went right? What went wrong? What can you do better? If we let this go by without planning, we've had other pandemics, but we've not really shut down, right? So we had the swine flu, we've had the avian bird flu. It seems to me like about every 10 years we're having another pandemic. So this one was a little more unique. What can we learn from it, and how do we move forward? So as we did a poll as we move to the next slide. Just basically we did by the numbers. We wanted to share some insights. You can find this on our website as well, but I pulled out some interesting statistics for you to take a look at, and kind of what members are doing. And this is going to be different. I would encourage everybody, look, if you're in a white collar environment, you have a little bit easier way of saying, hey, you might be able to work from home. Let's figure out how we can do that. In the blue collar environment and manufacturing environment, or places where we're food service, where we're working closer to each other, I think employers are going to have to maybe start looking at, kind of what we did when they went through total quality management back in the 80s, when they reworked their workstations and brought people together and say, how can we make it better? How can we improve our productivity? I think in the process of improving productivity, it's also going to be, how do we safely, manage that so that we're not dealing, kind of spreading germs or minimizing the risk of that, because in the course of doing that, if you think about the next few years when we're not in a pandemic environment, the goal would be that the regular flu season becomes less, right? Because essentially folks are making better decisions as we're going through. So as we go to the next slide, there's this whole concept of, you really can't unlearn something, and I think that, as we're thinking about that, it's really, you have to, the thing that kind of stuck out to me was, when Asim this year said, once the war was over, it never really ended. We all of our clients and all the businesses that we're dealing with, we all rely on people to be successful. We have to start thinking about helping people cope today with what's right in front of them, and then managing, kind of looking for, as you're updating your business plan, how are you going to be ready for the next one? How can you make it better? So with that, what I'll do is I'll turn it over to John Elliott, and he'll talk a little bit more about some plan design ideas.
Yeah, thank you, Kevin. And then hopefully I've been able to reconnect my audio and everybody can hear me. So
you're doing great.
Thanks, Kevin. But okay, fantastic. Thanks, Kevin. So wanted to share with everybody just a lot of different ideas and a lot of different tactics that are available to employers, whether you're United Healthcare clients today or customers today or not, just resources that we're making available, as we go into the next stage of the COVID pandemic and start returning to work, is making sure that people have the right resources and they're available to everyone in your population, not if they just have a United Healthcare or a UMR ID card. So some of those resources that are available to everyone includes our system checker, which is available online, so that folks have an opportunity without through a premium app or any other special access to this online checker to check their symptoms and see whether or not they have COVID or not, or if they should seek healthcare services or not. But what we've also found is, while maybe you have symptoms, and whether it's the flu or COVID-19, most of the population is dealing with some sort of behavioral stress, anxiety because of the COVID crisis. So much more of the population is having behavioral challenges, dealing with the crisis, whether that is simply dealing with children at home and a spouse at home in a work from home environment, or someone grieving for a coworker or a family member that they weren't able to see before they passed. So a lot of increased utilization and free access to an emotional support line. United is also making our Sanvello Health app, the premium version of that app, and resources available at no cost. And then also for those with multinational populations, again, through our EAP, a lot of support and a lot of documentation and resources are available to employers that help with how do you talk about grieving for a coworker or a family member. A lot of great resources that are available to employers to really have additional information, or as much information as you want for your population is available through some of these different sites. And then Rick, on the next slide. Some other more specific things that really get into options that are available to you, again, whether you're a United Healthcare customer or not, but a lot of return to work options. So within the last 24 hours, United Healthcare and UMR is making it available to our customers what we're calling a return to work toolkit. That will have information on a state-by-state basis in terms of what sort of types of businesses are open and at what capacity. Other tools and other reminders of some of the tools that I just mentioned before that are available to clients. But also for our clients, our Optum division is also making a lot of different return to work options available to really meet an employer's unique needs for their return to work strategies. And some of those are pretty basic when you think about some of the essential tools that we're offering. Protect Well is an app that we are piloting with a number of our clients today and is available through Optum that, again, provides you with an app-based symptom checkers so that before people report to work, they can report their systems, check in before even showing up to the work site to make sure that they are ready and safe to enter the work site. Optum is also providing more comprehensive needs and services where you can work with Optum to provide either on-site clinicians or telephonic resources to support different worksite locations to really, again, test and see if anybody has symptoms before entering the workplace. And then, custom solutions, if there's more need for on-site clinical care or physician care or testing care, can really customize a lot of those return to work strategies. So a lot of great variety in here and flexible options to really scale up or help you prepare as much, whether you're opening a small site or want a major location for your population. And then finally, on the next slide, Rick, another area that, we've had a lot of conversations with our clients in really that whole balance of, now that we're getting to a state of normalcy or really understanding COVID and coming to grips with where we are right now, obviously there's the business side of our organizations as well too, and how do we preserve our current healthcare strategy but yet meet the organizational cost savings that are needed. Many of our clients are coming back saying, we need to find X percent or Y amount of dollars for the organization in terms of savings. And so a lot of the guidance that we've been providing clients here in the short term is really not worrying about, what is your plan design strategy and what is your network strategy and what providers that you make available to your population, but instead refocusing on a lot of different plan design elements where there are a lot of savings opportunities that really may not jeopardize your overall strategy, and some of the things that you might not have focused on before can become important as we're looking for all potential savings during the pandemic. So as you think about, some of the savings in terms of making sure that people are following the right clinical guidelines, following evidence-based practices, looking at the type of services that require medical necessity decisions, offer savings to employers if you haven't, taken the most advanced options that we have to offer in those regards. But then also thinking about, your payment policy under your plan. Is this really the right time to be covering experimental procedures for cancer or other types of procedures? How are you reimbursing out-of-network care, over the next year or 2 years as you're looking to have savings? In addition, there's a lot of different opportunity as well as a lot of different fraud, waste, and abuse programs. A lot of different employers over the years, have really not taken a deep dive on some of the payment integrity options that we have. We've also come out with a lot of different enhanced programs that use machine learning and AI technologies to really identify and spot new patterns of fraud that are now available that some of our clients have not taken advantage of. But again, as a different reminder before, changing your overall kind of benefit or reimbursement or premium strategies, just these are reminders of a couple different levers that you're able to pull as you're looking for organizational savings. So with that, Rick, I will turn it back over to you.
All right, thanks, John. Thanks, gentlemen. We don't have any questions so far from our audience, but I was wondering if John, either you or Kevin, could respond to, with parents with kids and not going to primary care visits like that, and actually adults even not really following up with primary care right now. When you think about resilience and you think about getting back to work, how do we get people back to primary care or just back to treatment prior to COVID-19? How do we remove some of that fear for these folks, and how do we get them so they're getting vaccinated, they're getting checked up, they're going and getting their elective surgeries, et cetera?
Yeah, Rick, this is John. I'll take a. Oh, go ahead, Kevin. I'll let you go.
Yeah, so I'll start it from a Health Action Council perspective, and then let maybe kind of John add on from a UHC perspective. I would say first and foremost, what we're seeing in the data right now is that vaccination rates are way down because essentially, primary care visit for pediatricians were considered to be non-essential services, so kids have missed services. So number one, as a plan sponsor, you want to make sure that folks are dealing with, kind of getting back in and getting vaccinations done. You can do that at a primary care office. As I'm reminded frequently, Walmart, which is still open, offers vaccinations. So there's plenty of ways to get them if there's a discomfort about going into a location where you're ultimately managing that. So I think there's going to be a little bit of that. And then we recently did our, a study on our end regarding at Health Action Council along with UHC on virtual visits. I would encourage people to start looking at their virtual visit practice. Are they encouraging that? Are they covering them? Because I would imagine you'll start to see virtual visits. We're starting to see virtual physical therapy benefits and MSK type treatments pop up. Just making sure that your plans are covering them and providing that flexibility. That's from a Health Action Council perspective. John, I'll let you add on to that from a UHC perspective if you'd like.
Yeah, no, thanks, Kevin. The only thing that I would add is, Rick, one of the things that we're definitely working with our employers on, and what we're doing with like our regular preventive reminders is really, the data that Craig was showing is, what local healthcare systems and markets are primary care offices ready to start seeing people for preventative visits, or are their practices still dealing with people with severe respiratory issues? So that would be kind of the first thing is, making sure that the local primary care marketplace is actually ready for preventative visits. Assuming that they are, like Kevin said, if folks are nervous about going back to that, then whether it's telehealth or virtual visit type visits, that's a great way for people to get, stay connected with their primary care physicians, until they're safe or until they're ready to, take part in terms of vaccinations or regular kind of standard preventative care checkups. And then, Rick, the last thing that I would also suggest, and mentioned a little bit in my remarks too, is telemental health is also another great resource, and we've seen quite a bit of higher utilization for people that are dealing with either anxieties about going back to work or going shopping or going back to the doctor's office. Again, another great resource to help people prepare to enter back into either society or into the marketplace. Another great, convenient way for people to make sure that, their concerns are being met and they've got the right mindset to re-enter the workforce.
Great, thanks, John. This is from Shayna out in our audience today, and it might be appropriate for Craig and or Kevin. Do we have any comment about what we're hearing about hospitals being incentivized for having COVID deaths, leading to a misrepresentation of the numbers? Has Health Action Council, or for that matter, has United Healthcare looked into that at all?
I would say we have heard of those potential issues, not specific to what the motivation was, but that there appears to be wide variability in how states are recording, not just states, but how states and different agencies are recording COVID mortality. That is a key variable into the system, and it's hard to account for. Some states, it's much more strict and more legitimately directly tied to a distinct COVID diagnosis. Others, it could be an associated diagnosis or likely symptoms, and a little bit broader categorization of mortality. So I don't know if we know the reasons and the motivations behind some of the differences that we're seeing, but we definitely understand that there are differences in how different states are recording specific COVID mortality. And even if you look at examples like what you see on the CDC website versus what you see on Johns Hopkins versus World Meter and the different COVID sites that are out there, everyone's kind of categorizing things a little bit differently, and we are working to find what is the source of truth for COVID analytics.
Yeah, and so Shanna and Rick, from a Health Action Council perspective, we asked, pretty early on about this. Anecdotally, I can tell you, a lot of family and friends and relatives up in the New York, kind of New England area. So have heard, one family member, somebody passed away from a heart attack. They did testing after the fact. Turns out that they did have COVID. They did, kind of identify that as a COVID-related death, not as a heart attack for the purpose of death. What within a commercial plan, and we'll continue to work with Craig and the UHC team to make sure that the reimbursement schedules, the amount of payments that are going out are not inflated. I would think that based on volume and activity, there is, depending on what happens on the Medicare space and how the reimbursement may come, if there's another federal stimulus, kind of money that's coming out, some of these folks may be thinking, hey, if I run up my COVID-related information deaths, I can, try to extract some extra dollars out of funding to pay off and kind of deal with this stuff. We work very closely with the folks from United. They have very, very good algorithms to make sure that their contracts are not incentivizing people and paying them more money if it's COVID related. Rick, any more questions?
Yeah, just a couple more, gentlemen. Thank you for answering these. So who is paying for COVID-19 tests? Is it the employee? Is it the employer? Health systems? Is there, if the employee does have costs to this, are there tables being put together, like a range of prices for cost, reimbursement, et cetera?
John or Craig, do you want to handle that one?
Yeah, Kevin, this is John. I'll respond, and then Craig can add some additional color. So I guess, Rick, a lot of good questions there, because and again, it really depends on your local marketplace. I know in certain areas, health systems have offered to provide free testing for people that are individuals. Know that if you're if you have populations in the New York, New Jersey area, that some of the testing, some of the reviews are covered under FEMA. But if you go to some of the drive-up kind of locations, related to your local healthcare system, it might be related to the contract schedule that we have. So not a great answer, but there's a wide variety of whether or not a service is being provided free, or if there is a charge. And if it is a cost-related charge, then many of our employers for COVID testing and some of the national requirements, as you think about, what's the split between the employer and the member receiving the service, that many of the COVID testing, if not all the COVID testing, is being reimbursed at 100% by the plan, as a lot of the federal mandates. But then as you get into, COVID treatment and that's where, at least for self-funded employers, there's a variety in United Healthcare providing a lot of different payment options for employers that could elect into to really determine, what is happening for the rest of the treatment.
Nothing to add, John. You had all the points I would have.
Okay. Okay.
Yeah.
Well, and Rick, and I apologize for the person asking the question, because it's not a definitive answer. It kind of is. It depends, because there is a wide range, and it just depends on where the test was received.
Gotcha. Okay. One last question about testing, and I know Craig and I spoke about this in the past. There's one last question from the audience. Are home test kits for COVID-19 available? But just as a follow-up to that, Craig, in addition to that, has there been any identification of what the most effective test is? Has there been any updates in reliability, false positives, et cetera? Is there one definitive test, and how effective is it? Are the home tests better, worse? Do you speak to that?
I'm not a clinician, so I won't speak to all of those pieces. But in general, we are seeing that there are many different, wide variety of tests that are now available, wider variety of methods. Looking at the outside of the nasal passage, there's now a saliva test that folks are beginning to start to use. Home tests, some of the original tests. What we are seeing is that specifically for testing on the disease itself, the virus itself, that the reliability in testing as far as finding the positive tests is much more accurate than the potential false negatives that pop out. So if you do test positive, it's very, very likely that it is a true positive. If you test negative, there is still a portion of the time that you actually were positive but didn't meet the requirements for that test. What I would say is you start to jump into antibody testing. So I'd say fairly consistent, accurate results on the testing side of things at this point. It has gotten a lot more standardized. When you jump into the antibody testing, it's still highly variable with the accuracy, results, and usability of the antibody testing at this point. I think it's getting better, but we're still not there for antibodies.
Gotcha. We're all working through this together. So that concludes our question and answer session for right now. I'd like to thank the three of you, Kevin, Craig, Mr. Elliott, I really appreciate you guys coming on today. For you out there in the audience, members of Health Action Council, I will post a copy of the slides from today as well as a copy of this presentation with audio on our website. For any of you out there that aren't members of Health Action Council, if you have any further questions or require any access to any of the materials from today, again, please feel free to reach out to me at rwestfall@healthactioncouncil.org. That's going to conclude our session today, everybody. I hope you have a great week, and let's all stay safe and keep moving forward. And thank you again, everybody.
Thanks, Rick. Thanks, everybody, for joining.